This is one of the last sessions about Ebola, but if you realize that the entire 2 or 3 days have been spent talking about Ebola more than any other conference we've ever been to or that we're going to go to in the year. And the reason for that is quite simply because we are all affected and touched by it, one way or the other. I can tell you for this conference itself, we lost, not lost as in gone, but we could not get 17 or 18 speakers because of various restrictions from the Ebola issues. So I want to talk to you about the lessons learned from Ebola. This is a photograph from the very first Ebola in 1976. And what we see here, if you can notice, is that there's a person walking around with a gown, face covered, head covered. There's a tub over here of chlorine in which they dunked all the instruments as well as the linen and anything else. And in the corner was something that was boiling, it was burning, and it was being used for incineration. This was the scenario and the layout in 1976, when in fact in Zaire, if you remember, the name Ebola came from the Ebola River. It was interesting at the time that there were 2 outbreaks going on. And I don't know whether you noticed or not, but we've also just had 2 outbreaks again, one in the DRC and one happening in the other parts of West Africa. So in the beginning what happened, and I don't know how many of you know this, but between 2012 and 2013, there was an outbreak of Ebola amongst the great apes. Around the DRC and the surrounding areas, 5,000 of them died, and this went largely unnoticed. But the first case that happened in a human was in December 2013. So in fact, there was already a lot of Ebola activity going on in the bush, in the forest, and people were in fact coming in contact with these. And this was, as you can see here, the very first case of a 2-year-old. And I just want to remind you that the very vulnerability of the extreme ages becomes evident in this outbreak. This was again an epicenter because from there we started something quite large. It spread like wildfire, as we can see from this slide here, going from, excuse me, Guinea to Sierra Leone, going up to Liberia, and then of course spilling over and goes on and on. Now, in a low resource country, or in countries that we live in this part of the world, there's a very high level of superstitious belief. There's great dependence upon the reverence of traditional healers and leaders, even today. Stigma is attached, and here you see a person who's got Ebola written all over him. There are people dressed who are roping him in to try and drag him away from the place. The very first mistake that we make is we walk in without understanding the culture or the sensitivity of an area. And there was no traditional leaders or tribals who were actually included in this healthcare program. And from this environment, you can see in the inadequately infrastructure, it was a disastrous move. There was total panic and confusion. This is a photograph that was found that I picked up from the Cape Times in South Africa. Ebola's tragic toll, and I want you to note that everybody's standing around not knowing what to do, some with their back to the poor chap, and he's just lying there bleeding and dying on the street. Unacceptable behavior for a human being, or even, in fact, not a human being, an animal. So the very first lesson is involve the community. Don't walk into somebody's house and tell them how dirty it is if you don't even know the people. If you don't understand the culture, go and look and find the traditional leaders and the traditional heads. Talk to them first. If you come dressed in funny clothes with sprays, they are going to say that there's something nasty going on. And this lesson was not learned from the HIV epidemic. It's repeated with the Ebola epidemic, and no doubt it'll be repeated again and again and again. So here we've got some pictures from Liberia where the locals are talking and discussing Ebola. And at the bottom here is the son of a chief who actually sat and listened to the Ebola story and then went out, bought one of these buckets that you can see here. He brought soap and he started teaching hand hygiene in that community. So if you have them on your side, you learn a lot. And Frederick Murray has come down specially to talk to us about this because he is an expert in community-based participatory research. So that was the first lesson. If you don't involve the community, you're in the wrong place. Second is a weak healthcare system. This is the total population of Guinea. There's Liberia and Sierra Leone. But what I want you to note is that the number of doctors per 10,000 population in Guinea is 0.03. In Liberia is 0.1, and in Sierra Leone is 0.2. However, in Nigeria, they have the same population as the average for the country, for the continent. The nurses are very short as well, and in Nigeria they have lots of nurses. And the reason I've separated these two groups is because Nigeria managed to contain and control the outbreak very, very much better than the other three countries did. And this is a very important lesson to take back. A weak healthcare system. Now, I want you to note this chap over here. I think they are trying to do contact tracing. So we've got to look at the communication and improving contact tracing. Text messaging, SMS, WhatsApp, chat to each other, posters, I don't care. And a lot of that is going on, to be honest. But here's a guy who's walking around protecting himself with a plastic bag on his head, plastic bags on his hands, and he's walking around with this needle and syringe. He's trying to work out what to do with it. And here you can see where, in fact, there's quite a lot of disarray in certain healthcare facilities. Here is a very quickly made up unit which has got hand hygiene outside, people walking, but they're still milling around. They're still coming and going. There's no coordination, there's no structure. We've got to think about that very carefully. And then the third lesson is we don't know what's going on. Half the time we don't know what's happening. We guess, we'll read the newspapers. I got a lot of information from newspapers and from some publications that were not related to Ebola but were related to other filoviruses around. And we extrapolated. And of course, as you can note from this, the Ebola virus outbreak goes in cycles. So we are expecting a cycle. And had we done surveillance, we would have predicted this outbreak either in 2013 when the apes were dying or in 2014 coming in. So that is a weakness that has to be definitely strengthened. That's the third lesson we learn. This is Africa in December 2013. The epicenter started in Guinea, and then the next thing we know is Sierra Leone gets it, and then Liberia gets it, and then Nigeria gets it, and then Guinea, Senegal, and then, sorry, what happened then? And then Mali, and that's fine. And there was a separate outbreak going on in the DRC. And we carry on, and Guinea again, and so on. The first case outside Africa was, in fact, in September 30th. First case outside Africa. He just had 10,000 people in Africa. First case in Africa. Okay, here we go. So in Texas. And then we go to Europe. And then we go to the United Kingdom. And then we go to Sweden. And then we go again into Spain. And then we go into New York. And then we go into Australia. And all of a sudden, the funds just start coming in. They just pour in and pour in and pour in. Now we know that the Americans' lives are at stake, money is coming in, deployment of troops, I don't know why they're there, but I'm sure it's a good idea. Healthcare workers, find them, we don't have them, we need 5,000 of them. Mobile laboratories, mobile global systems, it's all absolutely there. This funding was there, and it could have been there in the beginning of the year. But something dramatic and drastic had to happen. And the idea is that you contain Ebola in West Africa and stop it spreading to Europe and America. That was the idea. And it's a good idea. I agree, totally. Having said that, we would like to actually make sure that people understand the concept behind which this was led. Okay. So the fourth lesson is the leadership gap. There are flaws in the international response. It was slow, it was uncoordinated, and everybody you talk to who's worked in the environment recently has come back and said, it's not coordinated. There are people walking in and out, milling around. Nobody knows what's going on. They're not particularly strong, and most of the global experts agreed to that. By the time the WHO said that there's an epidemic, life had become very difficult in these countries. And so that is another lesson. However, MSF was there already. They were dealing with malaria. They were dealing with, I think, some other epidemics. And they just walked into the Ebola outbreak. They were not really geared or prepared for it. But they stepped in, and they have to be commended for the amazing work that they managed to do in the time when they were there. And they still are. Now, there's a concept in the English language that said Nero fiddled while Rome burned. And I think we were looking at all this going on. The concepts of that come forward that Ebola could affect 1.4 million people in these countries by January 2015 on a predictive module. That's pretty scary. But why is this going on? And the reason is because the WHO budget was cut in the past 5 years. Lots of people were fired. Lots of people had lost their jobs. And they brought the budget down from 16 billion to 4 billion. With the greatest respect, there's no way that the current group that looks after patient safety, which is basically Benedetta, and her team around her, can cope with what's going on. So I appeal to you all, because all of you are Africans, to come forward, volunteer, and help and support this program. It is absolutely essential. Don't depend upon the WHO or CDC or other funders. Come forward and come through the ICAN program, and we'll see what we can do about supporting Bernadetta and the WHO and Africa, most importantly. So today we're sitting with a very large total. We've gone over 10,000. We are looking at mortality, about half of those, which is not nearly as bad as those in the past, but it's still a very high mortality, unacceptable, shouldn't be happening. So the fifth lesson, what happened? We sent a lot of untrained healthcare workers in to work with Ebola. Here it is, here's your ticket, there's the plane, go. Okay. So whiteboard marker in one hand, a little notebook in the other, and a lot of them will agree that they had the 2008 filovirus document that was produced by the WHO rapidly put forward. The MSF put out a document and everybody ran. And there was a major panic response. While on the ground, people in Africa have quietly been dealing with viral hemorrhagic fevers for years. We see Congo Crimean all the time. It comes and goes. We know how to deal with it. It's not a problem. There was no panic. Healthcare workers became affected. A total of 450 healthcare workers known to become affected, and here are the figures, which is 80 from Guinea, 228 from Liberia, 11 from Nigeria, 127 from Sierra Leone, and so on. But I think the point that I think Peter was making when he gave his talk was about why these were happening and why the incidence was much higher. I'm not sure that it was, but having said that, we cannot afford to lose healthcare workers where we don't have any. And that's really important, to send people out who are trained. One trained person is equal to having 10 untrained people wandering around aimlessly and being a complete disaster. And this is why infection control is the most essential aspect of this outbreak, and this is a lesson we must learn. The loss of these 244 was, they interviewed healthcare workers to find out where they got infected. And please note, this is absolutely incredible. 84% of them got infected in the patient's room. Now, if they understood contact precautions, that should never have happened. It just should not have happened. In feeding and talking to the patient, it should never have happened. Examining a patient, okay, possibly. Taking blood, okay. Laboratory handling, all right. Washing a patient, no. But what was very interesting that came out of this was that some of the healthcare workers who managed to get some PPE started doing private practice, going to homes and saying, I can treat your patients with Ebola. And that is where, in fact, 30 healthcare workers contacted it. In fact, 33 of them contracted it by being outside doing private practice, which is rather sad but true. The attack rate was highest amongst physicians, not surprising because they have the closest physical contact with patients. Nurses also have contact. They were the next round down the line. Technicians, I don't know why, maybe because they didn't understand contact precautions. And then there were some others wandering around aimlessly, 4, who just managed to get Ebola. Well, what was that all about? Why should they have that problem? So something is happening in the system. Directly affecting about 73%, indirectly 33%, I don't know how that is. Unlikely was about 64%, and unknown was 56%. So half of the people who were infected with Ebola didn't know how they got it. How is that possible? How do you not know when you put yourself at risk? The question is, how infectious is Ebola? What are we talking about? This thing that's going to kill us all as we sit here and talk to each other. We don't shake hands, we knock elbows together, we rub noses or whatever. What is this thing? Well, it's got the same infectivity as hepatitis C. For every case of Ebola, you will only get 2 people infected. When you look at the other end of it, and particularly after Charles Basongi told us on the measles outbreak, look at the number of cases we infect with measles. But we don't behave like that. It's airborne, we know what to do, we put it into perspective. Ebola is not as infectious as we're making it out to be. What is infectious is our bad IPC practices. And if we don't contain those, we will put ourselves into risk. So, come back to the basics of IPC. Lesson 6. First IPC principles come first, which is triage, testing, separating confirmed and other cases, environmental cleaning. The basic principle of the environment is keep it clean and dry. I'm saying ventilation because I'll explain to you why in a minute. I don't know why we don't have ventilation in this environment. And PPE is the final one, as we all know. Contact precautions is all you need. What you do there is you have to isolate the patient, Hand hygiene at every moment, and this is one place we will break the rule and say hand hygiene at all times. If you can help it, even if you're wearing gloves, try and get rid of the contamination. Wearing gloves, splash protection, and skin protection. That's it. Okay, so now let's look at what's happened there. I want you to trust your knowledge and not your fears. What knowledge do you have that tells you the evidence that this will be transmitted in any other way? It's not coming by air. So what do we see here? Dressing up for Ebola. Okay? The guy has got gowns, he's got this, he's got stuff on his feet, he's got water, and I don't think I'd like this guy coming near me if I've got Ebola, to be honest. And then we've got the people from MSF who have got double masking, they've got goggles, they've got gloves, taped down, they've got over gloves, under, I don't think they've got over and under gloves, they've only got one set of gloves and so on. And then there's the local bloke who's doing Ebola. He's got his helmet on, he's got his legs sticking out, and there he is with a pair of plastic bags on either hand. Okay. So, there's a person who looks after family with a plastic bag over her head and a big N95 respirator. Her eyes are totally open, so if they're splashing, she will get contaminated, and so her risk goes up. But we are agreed that Ebola is not airborne, so what is going on here? And even no matter how much you say it is not airborne, if you walk around with an N95 respirator, people will say it is airborne because we have been taught by the TB program that N95 respirators equals to airborne. End of story. So you're confusing messages coming from the healthcare workers and from the big institutions. Sorry, let me go back. Okay. This is the difference in isolation facilities. My old hospital, the Royal Free, where I used to work, you've got a lovely trixilator, the guy lies in there, you stick your hands in there, talk, chat, shake hands, feed him, do whatever you have to do. You're on the outside, you change, you don't change, it's okay. It's ventilated. There, on the other side, is an institution which is running at 35 degrees outside, plastic bits in the middle, there are buckets lying all over the place, and the floor could be either clean or dirty. Difference in isolation facilities. I know, we just talked this morning with Ravati, there are wonderful new institutions that are being built, like in Kenya and places like that. But till they come along, we survive in whatever we have. And the problem with that is this. This is Barbara Spencer, who actually went from the Free, and she almost died of heat exhaustion. Basically, because of this sort of clothing we decided to wear, the shortage of staff, so they stayed on duty longer, they were overcrowding and bumping around in the facilities, there was no ventilation, most of the healthcare workers got heated inside, their core temperature went to 39, okay? And of course, there was a big problem because they lost function and they lost their sense. Yesterday, I was giving a talk downstairs in the drawing room and there was no air, and believe me, I could hardly think. My brain was getting very clogged and fuzzy, and that's just for a while. So the point I'd like to make is that the new institutions that are coming along, particularly the military organizations, have put in ventilation. Oops, sorry. They have put in ventilation. They have got in their temporary systems, and there's nothing wrong with it. Why can we not have a comfortable place to stay if you've got Ebola? Now, there's a lot of chlorine spraying going on. People being sprayed open and closed. There's one on the, I don't know what she's spraying. There's nobody there anyway. But over here is somebody else who's spraying. Now, some very basic facts about chlorine. It produces damage of the skin, which increases the risk of contamination with viruses, bacteria, fungi, and anybody else who's going around. You always have to clean before applying a disinfectant. And basically, chlorine is not an antiseptic for living tissues. It is a disinfectant for non-living tissues. Spraying does nothing because it just washes the chlorine, just washes what organic matter you have straight into your boots. You really need to wipe because you allow the contact time and for it to stay. But the basic principle of IPC is keep the environment dry and clean. So why are we spraying everywhere? There's no evidence for it. The WHO guidance are coming out, very rapidly produced, very widely circulated, and they have been adapted by ICAN. And there are other guidelines on the way, are they not? On waste management, which should be coming along very shortly, and then there's specific on protective clothing, what to recommend, how to use it. And hopefully, by the end of the year, there'll be 3 very solid documents coming out on the matter. And as Nizam mentioned as well with the WHO session, the CSSD document should be coming out, and we will be writing a page or 2 in that on filovirus protection. I'm not going to go into this detail because this is something you know, but there's a lot of fuss going on the taking on, well, putting on and taking off of PPEs, okay. So here's a bunch on the top here who are actually, I think, trying to get out of it. This is a guy at the bottom who's trying to get on with it. The simple principle is first on, last off. Okay, if you can remember that, whether you're on your own or you got a buddy, I don't know. And what you basically do is you remove the most contaminated thing, which is your gloves. You go into hand hygiene, keep on doing hand hygiene. For any excuse and any reason, I don't really care too much at this point. Avoid contact and make sure that you dispose of the items as you should. And that's simply quite clear. If you can get a buddy to help, because at Tigerberg, our protocol requires a buddy. They will dress you, they will undress you, but they will also stand and watch you while you're inside working with the patient so they can observe any practice. And we have loads and loads of checklists and PPE lists and so on that we can fill. So when you come out and you do your daily meeting, you can say, look, that was not a clever idea, or that was a good idea. And just avoid contact. So for me, the gown, which I've always used when I'm out there, is the easiest, because you strip it, you roll it, you keep on turning it till it comes out. If you go with the coverall, you have to go wiggling around and somebody's got to come and help you. And if it's hot and sticky, it's very difficult to get it off. The revised guidelines from the CDC are quite interesting. They went from goggles to face shield. They've gone from gown to fluid-resistant gowns or coverall, 1 pair to 2 pairs, and no leggings to fluid-resistant pants. And I don't know why. Why the pants? Unless you stomp on a patient, why are you going pants? Protecting your feet. What about the hands? You know, think about it. Again, we have to be very careful about what we say, to who we say it. This is just a very quick one about one of the layouts that we have on how to do an Ebola, an ATU center, Ebola treatment unit. Patients come in one side, support services the other, staff the other. They come through, they very well designed, very well organized. They come and go quite well. The seventh and the final one I'd like to say is please strengthen IPC. This epidemic, and I will quote Sade Ogunsola, I love Ebola, she said. If it hadn't been for Ebola, we would have not had the support of IPC that we needed. And I can actually second that and echo that. We needed an epidemic to be noticed. We've got a lot of financial support. We've had it from all over these institutions like CDC, WHO, MSF, Red Cross. But we need a lot of education. And the organization best placed to do that is ICAN, because we have trained widely, extensively, and we all in this room have experience as ICAN members of dealing with such matters. And we need to do sustainability and so on. So the point is, are you prepared? There's a survey monkey which sits on the ICAN website, which has been produced together with the ISC, and I strongly recommend that you go and fill it out. I filled it out for Tigerberg, and well, needless to say, you know, we're 92% positive. You know, we're just there, we know, we're prepared, and we have it. There's a massive Ebola preparedness around Africa. Please go to the website, fill out that form to see if you really have missed anything at all. Get your training in place and get your provisions in place. The Ebola training program at the moment has been set up with a partnership with the Unit of Infection Control, which is a 5-day course, and it will be run in Uganda very soon. It's got a curriculum with microbiology, the patient, the healthcare worker, the support services, the community, and communications around Ebola. It's slightly different to the average IPC thing that we have, but it's actually quite good. The IPC partnerships are with Samsung. They've given us some money towards a resource center. We're hoping to get money from CDC, Sierra Leone, the London Mining Company, WHO from Gorn. We're looking for volunteers. We've got 28 volunteers to date, to come and go out there to train whenever we're ready. For the community, we're looking at text messaging systems and WhatsApp programs if we can possibly do it. To summary, I'd like to say, please do not forget the basic principles of IPC. Good IPC is essential. It's the essence of being safe and sensible. We need ventilation, the environment has to be dry, and vaccines are coming. Now this is one thing that I have to show you because it's one of the funniest things I've ever seen. It's an important public health guideline from the United States regarding Ebola. I don't see a CDC link on this, but it says, stay home if you're sick, wash your hands regularly, do not eat fruit bats, do not fondle the dead, and do not kill healthcare workers. I thank you very much.